myelofibrosis. It is a clonal hematopoietic stem cell disorder associated with mutations in JAK2 thrombopoietin receptors or calreticulin, and it is characterized by myelofibrosis, extramedullary hematopoiesis, and splenomegaly. It is least common of myeloproliferative neoplasm and primarily affects men in 6th decade or later. Myelofibrosis can also evolve from other myeloproliferative neoplasms, including polycythemia vera or essential thrombocytosis. So, what is the pathogenesis of primary myelofibrosis? No cytogenetic abnormality specific to the disease has been identified. However, JAK2 B617F in exon 14 is the most common mutation, which is present in nearly 50% of primary myelofibrosis patients. Similarly, mutation in exon 9 of calreticulin gene occurs in 20 to 35% of patients, representing the second most common mutation, and mutations in thrombopoietin receptors occur in about 8% of the cases. These all lead to consecutive activation of JAK-STAR signaling as well as increased activation of JAK-STAR through other pathways as well. And all of these lead to proliferation of the myelin of the cells. Patients who do not have mutation in JAK2, calreticulin, or the thrombopoietin receptors are classified as having triple-negative disease, and these patients have worse survival. Development of obliterative myelofibrosis is the hallmark of primary myelofibrosis. So, let's learn the mechanism of the fibrosis in primary myelofibrosis. The pathogenesis of bone marrow fibrosis is not fully elucidated, but a theory suggests that the abnormal megakaryocytic cells produced in cases of primary myelofibrosis expresses cell adhesion molecule, that is p-selectin, on their intracytoplasmic vacuoles. The altered expressions allow the p-selectin to mediate the engulfment of neutrophils and eosinophils into the cytoplasm and stimulate the release of cytokines such as transformation growth factor beta, platelet-derived growth factor, and fibroblast growth factor from the granules of the engulfed cell. The activated cytokines then lead to fibrosis, neuroangiogenesis, and osteosclerosis. Fibrosis in the disorder is associated with overproduction of transformation growth factor beta and tissue inhibitors of metalloproteinases. Similarly, osteosclerosis is associated with overproduction of osteoprotein, which is an osteoclast inhibitor. Likewise, neuroangiogenesis occurs due to increased production of vascular endothelial growth factor. As myelofibrosis progresses, circulating hematopoietic stem cells take up niche in secondary hematopoietic organs such as spleen, the liver, and the lymph nodes, leading to the appearance of extramedullary hematopoiesis. Similarly, RBC production at extramedullary site is disordered. Along with this, the suppression of marrow function leads to moderate to severe anemia and primary myelofibrosis. Now, let's learn the clinical features of primary myelofibrosis. No signs and symptoms are specific for primary myelofibrosis, but patients present with symptoms like the constitutional one being fever, night sweats, weight loss, fatigue, abdominal pain, oral satiety, bruising, GI bleeding, and so on. Similarly, the signs include splenomegaly, hepatomegaly, cachexia, portal hypertension, ascites, and so on. About 10% of patients spontaneously progress to an aggressive form of acute leukemia, and certain mutations have been devised or identified as the risk factors for early death or transformation to acute leukemia, like ASXL1. WHO has given the diagnostic criteria for primary myelofibrosis. It includes the major criteria and the minor criteria. The major criteria include: first one, megakaryocytic proliferation with reticulin or collagen fibrosis. Second criteria is not meeting WHO criteria for essential thrombocytosis, polycythemia vera, BCL-ABL positive CNL, myelodysplastic syndrome, or other myeloneoplasm. Third one include presence of JAK2, calreticulin, or thrombopoietin receptor mutations, or in the absence of these mutations, presence of another clonal marker, the absence of reactive myelofibrosis. The minor criteria include anemia not attributed to a comorbid condition, leukocytosis greater than 11,000, palpable splenomegaly, leukoerythroblastosis, and LDS increase to above the upper normal limit of institutional reference range. Likewise, in peripheral blood smear, we can see neglected red cells, teardrop cells, that is tacrocytes, giant thrombocytes, myelocytes, and promyelocytes may also be present. Marrow is inaspirable due to myelofibrosis, and on bone marrow biopsy, in early phase there is hypercellular bone marrow due to increase in maturing cells of all lineages, and with progression, marrow becomes hypocellular and diffusely fibrotic. Similarly, the bone X-ray may reveal the osteosclerosis in the later stage. Likewise, the level of LDS and ALP both can be elevated. Dynamic International Prognostic Scoring System Plus, that is DIPSS Plus, has given certain adverse factors for the risk stratification and prognostication, and these include thrombocytopenia with platelet less than 1 lakh, anemia with hemoglobin less than 10 gram per deciliter, RBC transfusion then presence of constitutional symptoms, circulating level of blast greater than 1%, presence of unfavorable karyotype, leukocytosis with the leukocyte count greater than 25,000 and age greater than 65. Each factors a score of 1 is given, and according to that, a risk group is categorized. For example, low risk group consists of a score of 0 and has a median survival of about 15.4 years, and the high risk group score is greater than 4 and median survival is 1.3 years. Now, let's learn the treatment of primary myelofibrosis. No specific therapy exists for the primary myelofibrosis. According to the risk category, the therapy can be for the low and intermediate 1 risk. If the patient is asymptomatic, observation is to be done. If there is anemia, then erythropoiesis-stimulating agents can be given. If there is symptomatic splenomegaly, we can give hydroxyurea. Similarly, if the patient is intermediate 2 or high risk group, then ruxolitinib can be given, which reduces splenomegaly and alleviates the constitutional symptoms. Allogeneic bone marrow transplantation is the only curative treatment for primary myelofibrosis, and it should be considered in younger patients and older patients with high-risk disease. Patients with primary myelofibrosis can also develop the hyperuricemia, for which we can use allopurinol. Glucocorticoid can ameliorate anemia and constitutional symptoms, and combining these with low-dose thalidomide has proved effective as well. In conclusion, primary myelofibrosis is a type of myeloproliferative neoplasm which afflicts men in 6th decade or later life, with development of obliterative myelofibrosis as its hallmark, and no signs, symptoms, and therapy are specific for primary myelofibrosis. Thank you.